Hello, I'm delighted to welcome you to this Lymphoma Action webinar on managing symptoms and side effects of lymphoma. In this webinar, we will discuss the causes and management of symptoms and side effects of lymphoma, with a particular focus on fatigue, itching, peripheral neuropathy, and chemo brain. I'd now like to welcome Dr. Dan Monnery, who is a consultant in palliative medicine at the Clatterbridge Cancer Centre and National Health Service England clinical advisor for enhanced supportive care. Welcome, Dan.
Thank you very much for the introduction, and thank you for inviting me today to come and speak to you all about itch and peripheral neuropathy and lymphoma. So I'm going to try and do the topic justice, ladies and gentlemen. I hope that you'll be able to hear and see everything I'm presenting as we go through, and of course I'm very happy to take questions at the end. So I said it's niche, and I think it is. And the reason I say that is because lymphoma on the whole is quite unusual in the way that it presents and the breadth of complex symptoms that go with it. Sometimes the presenting symptoms are vague symptoms, and it's most unlike other cancers or blood cancers in that regard. And because there's so many different vague symptoms that go alongside it, trying to find ways of managing that effectively without bombarding somebody with a whole raft of medications is quite tricky, as we'll talk about. Added to the complexity of the lymphoma itself, the treatments are tricky in terms of their side effects. So there's a big side effect burden that runs alongside in terms of treatments that can cause nausea or pain or peripheral neuropathy, as we'll talk about. And those side effects can last beyond the length of the treatment, beyond the length of somebody even having lymphoma. So my role in palliative medicine, but more so in supportive care, is about symptom management running alongside somebody's treatment course. It's not actually palliative care, because these patients a lot of the time are actually pursuing cure or long-term control, and even beyond cure, there are still symptoms to sort out. So let's scrap, if you like, the whole idea that some of what we're going to talk about is palliative medicine, because I don't think it is. I think a lot of it is just going to be around symptom and side effect management, and we're going to focus, as I say, on itch and peripheral neuropathy. So we'll start with itch. Now, itch is actually a tricky thing, because we have thought for a long time that it's related to histamine. So you get a substance or bitten by an insect, or if you're sensitive to a certain medication, your body will respond by releasing histamine, which then causes you to itch by stimulating peripheral receptors for itch within your skin and muscle, and then that passes the nerve sensation along to your spine and then up to your brain, and you're aware, oh, I'm itching, something's bitten me or something's going on. And for that, you take an antihistamine. You can buy them over the counter, they work very well. But lymphoma is very different in that it has a number of different things going on that can trigger itching sensation. Histamine is still there as part of the mix, but actually there's a lot more interplay between the lymphoma and your own immune system that's triggering the itch. You've got interleukin release, which is the lymphoma and the body's own immune system fighting against each other. Cytokines, which are your body's attempt to fight off the lymphoma. Substance P is released in all of that. Substance P is actually a pain-related neurotransmitter, but low levels, it causes an itch sensation instead. And of course, within all of that, there is a little bit of allergic type reaction as well, where a certain part of your immune system that deals more with allergy than infection is activated and releases these substances called proteases, which all have their own receptors in your skin. They all have their own way of stimulating itch, but the pathway, by the time it gets to the spinal cord, has pretty much coalesced and you're dealing with the same sensation, but with lots of different original mechanisms. Therefore, when we come to treating itch, we've got to think, what are the causative mechanisms, acknowledging that we probably don't know which one is the most predominant until we've tried a number of different methods. And that adds complexity for us as health professionals, but it also adds frustration for patients, because you look like you're guessing, when in fact it's not an uninformed guess, It's acknowledging that there's a number of different mechanisms involved in itch, and you just don't necessarily know which one's right to begin with. And itch can be extremely debilitating. And I've met a number of people who are really troubled by it. I mean, it can progress to be quite a painful sensation. I've seen people who are not able to resist the urge to scratch and therefore can break the skin and introduce infections, which then has its own problems. The impact of continuous itching on somebody's mood is significant. The levels of depression associated with itch, in my experience, is quite significant, and sleep disturbance as well. People who are itching all night cannot sleep, and that then does no favors in terms of energy levels, mood, and everything else during the day. And all of this together really can affect somebody's independence, because if you can't sleep and you can't get yourself in a comfortable position, then actually going to work is just not an option. Going out and socializing and living a normal life, it's for a lot of people not achievable because of the itch at the root cause of it. So we shouldn't underplay itch as a significant symptom, even though it doesn't spring to our mind necessarily as a top level symptom to treat in the same way that pain does, you know? So let's talk about managing it. Now, first and foremost, I think the thing is the lymphoma treatment, we mustn't downplay the impact of that on symptom control. If this interplay between lymphoma and your own immune system is responsible via whatever mechanism for stimulating the itch, then treating the lymphoma deals with part of the problem. So that's got to be first and foremost. Supportive treatments. So the things that you would do for all kinds of skin itch regardless. So keeping the skin well hydrated using emollient creams and oils, using non-perfumed soaps, non-synthetic fabrics, all of that will help to some degree. And then once we've done those things, we can have a go at targeting the specific mechanisms, remembering that when I spoke on the previous slide, there are a few different mechanisms that could potentially be at play. So first of all, histamine. Just because it's not as simple as histamine doesn't mean it doesn't include histamine, and we can do something about that. We can choose a drowsy antihistamine or a non-drowsy antihistamine, like Piriton or fexofenadine. Now, again, there's a vogue more recently to go towards the non-drowsy antihistamines, but actually, if your problem is itching at night, you want a drowsy antihistamine. You want to be able to sleep, so it has its place. If you're dealing with substance P as part of that, then there's been some recent research that aprepitant, which was actually designed as an anti-sickness, is effective for substance P related itch because it blocks that receptor that substance P binds to in the spinal cord. The other thing I've put there is think about capsaicin, which is chili extract cream. If the skin is intact and healthy, you don't want to be putting it on broken skin. But one of the reasons I say it is because when we've got patients with pain, which is mediated by substance P, one of the things that chili extract does is it causes a burning sensation that then depletes all of those nerve cells of their substance P. So they've no further sensation to give. So if you put something like that on, it burns for a bit, not severely, but it does. Actually, it gets rid of the substance P, so that it then can't stimulate the itch sensation. So if there's a suspicion that substance P is the substance at play, that is something to try. If it's more interleukin driven from the lymphoma itself, then chemotherapy, as I've mentioned before, treating that lymphoma. There has been some low-level evidence about cyclosporin, but to be honest with you, immunosuppression, whilst you're having treatment for lymphoma, is not always safe, and therefore we may move towards a different measure that I'm going to come on to. And if you're dealing with more cytokine and proteases, which is inflammation and allergic reaction type responses to your lymphoma, then whilst chemotherapy can be effective at reducing that inflammation, steroids can also be effective. Now, we don't like steroids often alongside treatments because the treatments contain their own steroid regimes in order to make the treatments work. And if you've yet to start treatment, then having a steroid can reduce the likelihood of us getting a biopsy result that we can use. So steroids tends to be a bit of a naughty word. But if we're struggling and if the itch is overwhelming, it is something that we can think about. So that's the specific stuff for the receptor receptors insofar as we understand it, but there are a few other tricks that we might have a think about. First is menthol cream, creams that contain mint. Often a cold sensation can be quite helpful in the management of itch, and menthol creams are quite cold in the sensation they have when you put them on. I have known people coat their whole bodies in it, and that's quite uncomfortably cold. So, it doesn't harm anybody, but it's not something that I recommend. More recently, you'll see below in the diagram that I've circled the TRPV1 ion channel, where a lot of these pathways meet before the nerve sensation is sent to the spine. And that receptor is thought to be blocked to some degree by menthol. So if we don't know what the cause is, but we want to head upstream and cut it off where we can, menthol gives us a potential option. As does gabapentin and similar kind of nerve painkillers. If you can dull down the nerves that are sending that sensation of itch to the spinal cord, then that deals with the sensation regardless of the cause. So often what we find is combining a few different medications that will deal with the specific cause and add an extra layer of backup as well. And I've mentioned about steroids reducing inflammation, reducing cytokine and interleukin levels so that they can, so that the stimulation for that itch is reduced. There are also some other non-specifics that we can use. So there's a medicine called cimetidine, which reduces the production of cytokines by your liver, and therefore produces less stuff that can trigger an itch response. And that's particularly helpful when there are things floating around in your bloodstream that would ordinarily trigger your liver to release cytokines. So if you've got lymphoma, sometimes the inflammatory mediators that are being released get turned by your liver into something even worse for itching, and therefore cimetidine can be an option, but we have to be careful with chemotherapy because of the drug interactions. Mirtazapine, which is an antidepressant, has an antihistamine effect, but also has an effect on peripheral nerves sensing itch as well, that isn't fully understood, but some people find it effective. And also ondansetron I use from time to time. Sometimes itch, rather than being histamine related, is serotonin related. If you have too much serotonin in your body, you can itch as well. And ondansetron binds to the receptor that serotonin stimulates. So it gives us a few options of things to try. And also there is a trial as well that I've referenced here about carbamazepine, and that will work in a very similar way to gabapentin in that it reduces the transmission at the nerve level to the spinal cord of that sensation of itch, but it works in a complementary way to gabapentin. So you could use the two together potentially if you wanted to have an upstream effect on blocking itch. Now, you very kindly submitted some questions ahead of today's webinar, and I just picked a few of them to try and answer as we're going ahead. And the first is, does it happen around the site of the lymphoma, or can it be all over the body? It can be either, to be honest with you. There have been some case reports about it affecting people's lower legs and lower forearms predominantly, but it can equally be all over because of the chemical mediators that are released swimming around your bloodstream, stimulating itch sensation all over. Can it come and go? Yes, it can. And that may be affected by treatment, or it may be independent of that. And that leads into the next question of, should itching stop after treatment? Ideally, yes, but I have seen it where it doesn't stop after treatment. We still have to manage it after treatment has finished. And does it feel the same as dry skin itching? To be honest with you, I think a lot of the people that I've met would say it's much more severe. I've had some people say to me that it feels like they just need to rip their skin off, and to my mind, that is next level from dry skin itching. Moving on to peripheral neuropathy. So often in the case of lymphoma, this is caused by the lymphoma infiltrating peripheral nerves. It's damaging the nerves directly. It can be a response of what's called paraneoplastic, so your body is responding to the lymphoma and trying to fight it off, and the nerves get caught in the crossfire and get damaged by that. But the problem with peripheral neuropathy is that nerves don't heal very quickly, if at all, and we can therefore be left with the after effects of peripheral neuropathy, even if treatment has been fully successful, just because the nerves won't heal. And that makes it particularly difficult to manage in the long term. And the impact, again, from peripheral neuropathy is significant. Neuropathy can be painful. For a lot of people, it's painful. People will describe to me a burning sensation in their hands or feet. You can lose sensation, to not be able to do things like write or work loss of dexterity, so people tell me that they can't dress themselves because they can't do buttons or zips. A loss of mobility and balance can sometimes be the problem, where if your feet are flat on the floor, your brain stops receiving the sensation that your feet are flat on the floor, and therefore if you close your eyes, you lose your balance because actually that messaging has broken down. And all of this can have an impact on mood and independence and quality of life. But when we talk about peripheral neuropathy, we have a tendency to focus on limbs, hands and feet. And actually, peripheral nerves are responsible for much more than that. Peripheral nerves are responsible for making your blood pressure stay up when you stand from a seated position. So if your peripheral nerves aren't working, some people can find that their blood pressure drops when they stand up and they fall over. So we need to know about that and manage it. Cramp. Your muscles are kept loose when you're at rest by that nerve feedback. If you lose that, you can get really severe cramp. Constipation and bladder neuropathy. Your nerves, peripheral nerves, are responsible for keeping your bowel working and making your bladder work properly. And if they're damaged, then constipation or an overactive bladder, particularly at night time, I find, that can be a problem that we have to fix independently of everything else. And also delayed gastric emptying. It's your peripheral nerves that tell your stomach when it's full and needs to empty into your bowel. And if that mechanism breaks down, actually people find that they're really struggling to eat and drink a suitable amount because they just feel full all the time. So it is a significant thing. Management, again, it comes back to first and foremost treat the lymphoma, because actually if we can remove the ongoing damage to those nerves, we're more likely to make an impact. There's nothing I can suggest that's going to prevent it, and I know that's a shame to hear, and there are some research projects going on looking at cryotherapy or exercise through treatment to try and reduce the damage that's done to nerves, and at the moment there's nothing out there that says this is definitely going to be helpful, but I have seen. Treat pain. If neuropathy is painful, we must get on top of that, and there are various medications that we can use for that. Duloxetine's got decent evidence that it helps, but also things like the gabapentinoids and tricyclic antidepressants like amitriptyline, they can be really effective for nerve pain. So even if we can't fix the neuropathy, people should not be expected to put up with pain. Focus on function and involve physiotherapy and occupational therapy early. I've told you all of the things that neuropathy can do to independence and mobility, and actually we must, if we can, preserve function and mobility despite peripheral neuropathy to try and reduce the impact it has on somebody's overall lifestyle. Managing the end effects. If peripheral neuropathy is affecting somebody's ability to get up out of a chair and walk about without their blood pressure dropping, then we could give some fludrocortisone to keep the blood pressure up. If they're having cramp, then we can treat that with Pridinol or baclofen. If they're having bladder spasm, meaning that they're up 5 times a night to have a wee, there is a bladder relaxant that we can use for that. So even though you can't fix the nerve, you can do a lot to fix some of the problems that then goes on to cause. I've also got a list here of a few things that some people have told me they find helpful, even though I can't point you in the direction of any research that says it's helpful. So some people find exercise helpful, and that can be swimming or it can be brisk walking. Anything that's minimal impact and increases blood flow to the hands and feet can actually help return some of that sensation. Not all of it, but some of it. Acupuncture and reflexology have got some interesting results that actually I'm hopeful that in years to come we might actually find some really good evidence around those things, but some patients say to me that really, really helps. And cooling or heating creams. I've mentioned both menthol and capsaicin creams before in this presentation, but actually if your neuropathy is such that you feel that your hands and feet are burning, something like a menthol cream will take that burn away by cooling it down. Equally, if you feel that your hands and feet are as cold as ice and no amount of warming them up can be particularly helpful, that chili extract cream can be quite helpful as well for that. So it's part of masking the symptom, but some people find those are the things that stop them from being able to do day-to-day life. And again, I've picked a few of your questions to answer as we're going along. So any advice for managing peripheral neuropathy, particularly at night when it's preventing sleep? Well, when I've met people that describe that to me, it's mostly pain at night from the peripheral neuropathy that's keeping them awake, that burning sensation in the feet at night. And I would say actually a nerve-related painkiller like duloxetine or amitriptyline could be really quite helpful for that. Can it flare up months after treatment? Yes, it can. And if it's more down to the chemotherapy than the lymphoma itself, there is something called a coasting effect, where actually peripheral neuropathy does get worse after the treatment has ended. It doesn't make it any more treatable, but actually it gives us a bit of a sense as to what might be the factor that's triggered it. Can peripheral neuropathy cause permanent damage and cause disability? Yes, it absolutely can. And that's why I emphasize the importance of involving physiotherapy and occupational therapy early, to try and preserve function, because if we leave it to the point where it's taken somebody's ability to cope independently, it's somewhat harder to get that back. And then somebody has said that they're paying for physiotherapy to help with the impact of peripheral neuropathy. Is this usually needed? Physiotherapy, I think, is usually needed. Having to pay for it, I don't think should be. I think that actually that physiotherapy for peripheral neuropathy is something that should be available at your local treatment centre.
Thank you ever so much, Dan. That was so helpful to help us understand the reasons behind itch and peripheral neuropathy. And thank you for all your helpful ideas. We do have a question, and that is, where should people go for help in prescribing some of these remedies for itching that you suggest?
So it depends what's available to you locally. So I mean, it's the kind of thing that if you have access to a supportive care service near you, and these tend to be based in cancer centres, there are 22 of them around the country. If you live in the catchment area of one of those, and their supportive care team would see you and deal with that. Alternatively, some places don't have a supportive care clinic but do have a late effects clinic. That's the kind of thing that they would deal with, particularly again with that physiotherapy, occupational therapy, being able to access those there in late effects clinics commonly. I think if you're not sure what's available, a conversation with your GP is very, very worthwhile, because GPs can prescribe much of this and may be able to refer on to that extra layer of support and know what's available local to you. So I think a conversation with your GP is often a time very well invested.
Thank you. Thank you very much, Dan. Really fascinating talk. So thank you. I'm now delighted to welcome Nikki Catchpole. She's the clinical lead at Bath Centre for Fatigue Services, and she's going to talk to us about fatigue. Welcome, Nikki.
Thank you for your introductions, Anne. Yes, so my name's Nikki, and I jointly lead the service that we run in Bath. We have various pathways to our service. We see a whole range of different conditions where fatigue gets in the way of everyday function, and cancer-related fatigue is one of our pathways. Just thought I'd give a little overview of our short session today. We're going to have a little look at the definition of cancer-related fatigue, and that's going to be our starting point. I'm going to focus on a few helpful tools briefly, and then, as Dan has done, I think most of the questions actually that have been posed ahead of time should be covered. I'm conscious that there may be one that we may just need to look at. So, cancer-related fatigue. This is a definition that has been around for a little while and still does the job, really. And I'm going to just break this down a little bit because there are some key bits in here that I think are really important to understand, and I've bolded a few of those bits up. So cancer-related fatigue is a persistent, distressing, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. Okay. I think it's really important to clarify that subjective sense does not mean that it's not real, and sometimes I think that can be a bit misinterpreted. The subjective sense means that it's unique to you, and that's one of the challenges of fatigue, is that everybody's experience of fatigue will be slightly different. There will be a combination of factors that are likely to be contributing to your picture of fatigue. Dan's talked about some of the things already this morning in terms of particularly pain, and pain and fatigue have a complicated relationship, and pain can certainly impact on levels of fatigue. The other thing that I think is really important to clarify here is that we're not just talking about a physical tiredness, a physical fatigue. We experience fatigue and tiredness in physical domains, also emotional and cognitive, and I think that's really important to just raise awareness about, really, because I think we tend to be a little bit more in tune generally. This is a generalization, but generally a little bit more in tune with the physical side of things. Probably relatively in tune with the emotional side, but I think the cognitive side of things can get a little bit overlooked at times, and that's probably because it's not as well understood and recognized. And then the other bit just to mention here is that fatigue, of course, in everyday life is normal, but this fatigue that people experience with cancer and cancer treatments is not proportional to recent activity. And interferes with usual functioning, and that's where the distress can come in, of course. So when does it occur? Okay, so it may be experienced before diagnosis as a symptom. It can be experienced at and around the time of diagnosis, during the active treatment phase, which I think is probably a bit more sort of recognized, and then during the post-active treatment phase and beyond. And it can last for a number of years. And of course, it can impact on all aspects of life. Okay. Often we, as an occupational therapist, I will look at things in terms of self-care, productivity, and leisure. Self-care, everything that you do to keep yourself well, and that's about eating, sleeping, getting washed and dressed, those sorts of things. Productivity, which may be paid employment, it may be voluntary work, it may be looking after children, elderly parents, it may be doing the garden and house chores. And then the leisure side of things, everything that you really want and need to do. And being unable to do those things can, of course, impact on our sense of balance in our lives, and can lead to a sense of loss of self on occasion as well. This is a patient quote for cancer-related fatigue. I have not got the energy for day-to-day lifestyle. Most things in life take a lot longer to complete, and you have to work harder, i.e. to keep up with the challenges of work or even to socialise. Pre-cancer people seem to live life in the fast lane, whilst you feel as if you are on the outside looking in. These are, this is from data from our cancer-related fatigue pathway, reported frustrations of people that are experiencing cancer-related fatigue. Not being the person I was before the cancer, not being able to live life as I would like to. And interesting that, you know, we all develop coping strategies. Some are more helpful than others, and these are strategies that people that have been through our service have said initially when they first accessed our service. These were some of the strategies that they were using to just try and cope and get through day to day. So putting a brave face on things, just getting on with it, pushing on through despite the fatigue, keeping a low profile, and being grateful that I'm still here. And the pushing on through is a really interesting one, because often people's attempt not to give in to things can often mean that they fight it and push it, and can develop what we call a boom and bust pattern of activity and energy use, which means that, you know, you may have a day where you do a bit more, and that may be driven by some frustration, and then you might pay for it. And that pattern, that boom and bust pattern that often occurs with many fatigue-related conditions, is not sustainable. It's not a helpful pattern. It's very understandable how it occurs, but it's not sustainable, and it means that it can impact on things like ability to go to work. How can I plan? How can I sustain my activity levels when I'm just all over the place? I'm up and down all the time. So what can help? It is useful to have some awareness of your current energy and activity levels, and what's available to you from an energy point of view, available and sustainable, and that's a really a key word. And part of that is learning to recognise what might drain your battery, and we often use that battery analogy in terms of energy, what might drain your battery and what might recharge your battery as well, because that's really important. Remembering, of course, that this isn't just about physical activity, it's about emotional and cognitive activity as well. This is something that I'm aware is available on the Lymphoma Action website. It's a tool that we commonly use, and I'm a big fan. You can see it's quite simple in its format, and that is very deliberate, because sometimes we can overthink and overcomplicate things in our attempt to try to make sense of what's going on, which is obviously a very natural human reaction to what's going on. This is an activity rest and sleep log, and the idea, I'm going to go on 2 slides actually. There we go. The idea is that we build up a colour picture of where our energy is going, and how our routines are structured. You can see at the beginning of that first week, there's a bit more red activity. Okay, so going back, red activity is high energy activity. Yellow activity is a lower energy activity. There's a bit more red activity at the beginning of that week, likely pushing into that boom and bust pattern, and there's not so much at the end of the week. Everybody's balance will look different, of course, but this is a fantastic tool to help people to think about, what is it that's high energy for me? There is no one size fits all. There is no prescription to say this is how it works, this is what you do, this will make it better. It's about the understanding and awareness of how your mind and body uses energy, and we're all different. What's high energy activity for one person won't necessarily be high energy activity for another person. Okay, that's where it's subjective, it's your experience, it's unique to you. But understanding what is high energy for you is really important. Understanding what might fit into that lower energy category is really important, and also thinking about what is it that's restorative for you. And that can be a bit of a challenge to work out. And what this tool can help us do is to set a baseline, understand what your available capacity is, because if you understand what your available capacity is, it can allow you more confidence in being able to plan your activities, prioritize what's important to you, what's meaningful to you, in order to get through your day-to-day. It also helps to minimize that boom and bust pattern that we always see, bearing in mind that there will always be ups and downs in life and energy use, because that's the normality of life, and we have to be realistic and mindful of that. So that's a really helpful tool, the log. I find it puts the foundations in place. Often people will look at that initially and go, well, what is that going to give me? How can that help? I've started to talk about how it can help, and we use it an awful lot in helping people to think about a phased return to work if they've been off work for some time, in thinking about how much energy do they actually need to even start that process. What tasks do they need to do at work? How much energy might they take? How many hours at work is useful to start? And how do we build things up from there? So it can be really, really helpful. We could go on talking about fatigue for a really long time. So a few tips for everyday coping with fatigue. Establish a consistent, balanced routine, and the log can help with that. Prioritize, plan and pace your activities. That's easy to say, and pacing activities is a term that's used a lot. Sometimes I find it can be a bit confusing because people don't really understand what pacing the activities are, and again, that's where I would come back to the log and helping to unpick that some more. Consider what and where physical activity might fit into your routine. We haven't talked about physical activity or exercise in detail in terms of fatigue. We do know that physical activity can be helpful in managing fatigue. It has to be the right physical activity, and I tend to use that term rather than exercise, because sometimes exercise can put people off, and it can also result in people thinking that they've got to do much more than actually might be sensible for them. So I tend to use the term physical activity, and getting people to think about keeping moving, Dan's talked a little bit there about the importance of physical activity, exercise, and keeping moving from the peripheral neuropathy perspective. It's an important part of life, but it needs to be done in the right way. And again, that's where the log can help to factor that into a helpful routine. We know, obviously, I think this is a given, good sleep routines are helpful. If we're not getting good sleep, and there may well be some reasons for that, such as itching or pain, then some treatment for that may well be helpful to assist with sleep routines and have a secondary knock-on effect, of course, with the fatigue. Be self-compassionate. I think we put a lot of pressure on ourselves at times. We have in terms of our expectations of ourselves, and not wanting to give in. And sometimes this is not about giving in; it's about working with it. Okay. Ensure you allow yourself restorative time, and that's a conversation we have with majority of 95% of our patients, if not more, that they don't allow themselves, they don't feel that they should be doing a restorative activity when there are so many other things that they feel they should be doing. Allow yourself some restorative time and work out what that is for you. And actually, in our experience, that doesn't necessarily have to be for long periods of time. Restorative time is about quality, not quantity. And then make your goals realistic and meaningful. And that, again, brings me full circle to that log and making it consistent, realistic, practical, and meaningful. And that's a really key word for us, because without the meaning behind what you do and why you do it, that's when people will go, well, what's the point then? These are some of the questions that came through. In terms of causes, we don't know what causes a cancer-related fatigue, but we know that it can happen at all of those points in a cancer journey. It's not inevitable that you get cancer-related fatigue, although I think between 75% and 90% of people who have a cancer experience will experience cancer-related fatigue to varying degrees. I don't think there's any evidence to say that any particular type of lymphoma would impact differently, although obviously various side effects may impact on additionally on fatigue levels. We've talked about the fact that it can last, for some people last quite a long time. That doesn't mean to say that they can't have a good quality of life, however. Is there medication? And that goes back, there isn't any specific medication for fatigue per se. However, if there are other things that are interfering, such as pain, it may be that there are some pain medications that may help, and again, that impact on levels of fatigue as a secondary factor. And we've talked a little bit about coping strategies in a short amount of time. I wanted to finish with some patient feedback from our programs. Our programs are not aimed to fix it all, but they are aimed at understanding oneself in terms of energy use and thinking about quality of life in particular, and both a physical adaptation alongside a psychological adaptation to what's going on. So it's helpful to discuss experiences and consolidate strategies as part of a routine. Although it didn't fix it, what it did do was help me understand. Okay, just to feel that I'm not alone. It is a problem, it is real, there is hope, and could put my needs first sometimes, and that's a big one for a lot of people. I developed a new set of tools which have improved my quality of life. I can see progress in the goal of returning to work. And then just a few references there.
Thank you, Nikki. That was really interesting. And we hear from so many people that struggle with cancer-related fatigue. So thank you for giving us some background and also some really valuable ideas on how to cope with fatigue. I'm now like to welcome Charlotte Bloodworth, who's our last speaker of the day. She's an advanced care practitioner in haematology at the University Hospital of Wales in Cardiff, and she's going to talk about chemo brain. Welcome, Charlotte.
So I'm Charlotte. Thank you very much for inviting me, and thank you everybody for coming to listen. I'm an advanced nurse practitioner in haematology, working from Cardiff. I qualified in 1995 and I've worked for the last 19 years in haematology. But unlike the last two speakers who were expert in their field, I'm not an expert in chemo brain, but what I do have is a wealth of experience to draw from. So hopefully I'll be able to share a bit of that experience with you and give you a bit of insight. So I'll follow the same pattern. I'll do a little talk first for the first 5–10 minutes, and then I'll go on to answer some questions that have been sent in. So I wanted to start, if I can get that's it, really at the symptoms of brain fog. So brain fog in general, sometimes physically it's a bit difficult to tell if you've got brain fog. You might feel like you have a thick head, you might have a heaviness to your head. So, you know, you might sort of hold it, feel heavy. You might have a bit of coordination that's slowed down. You might have some poor balance. But really, the main symptoms are quite emotional. So you have difficulty concentrating. You might have poor short-term memory. You might have a low mood. You might be a little bit quicker to tear up than normal. And then others looking in might be able to see that you can't multitask. You might avoid tasks or feel less confident about doing tasks, and you might be a little bit more irritable, and that's really because you're a bit frustrated. And I've said might with each of these really, because I'd say brain fog is different to different people. It's quite a subjective thing. You know, brain fog to one person means something completely different to another. And that really is where a lot of the problems come for trying to find some evidence on brain fog. So the causes of brain fog. So this is brain fog in general. So as we age, we definitely become a little less sharp. I'd say majority of us, myself included. Hormones as well, they definitely can affect your brain functioning. You know, we hear of pregnancy, you know, that seems common, you get forgetful. Menopause, the same, and some ladies monthly, sometimes they might feel sort of less sharp than others. Also recovering from illness. So illness, you know, definitely rocks you, and, you know, you lose your concentration. It's difficult to sort of get back to what you're normally doing. In the same way that being stressed and feeling burnt out, which means really you're really over stressed, that can definitely affect some of your sort of cognitive thinking. Not sleeping as well, that can definitely stop you functioning at 100%. And then there are nutritional deficiencies. So I don't only mean food, you know, alcohol as well, if you're drinking too much. Also medications might interfere with things. There is some evidence to suggest things like stress, exposure to toxins, and medical health problems can actually cause inflammation of certain molecules in your brain, and that can contribute to brain fog. But I'll come back to that sort of evidence or lack of evidence in a minute. So I took this off the Lymphoma Action website because I thought it was absolutely a perfect definition of chemo brain or brain fog. So, you know, my doctor told me to expect chemo brain with my treatment. I noticed my concentration was poor. It felt like a mental fog. I couldn't focus on TV. I couldn't focus on daily life. I just stopped mid-conversation because I couldn't think of the right words. And that really reminded me of that photo that I did on my sort of title page with that head that was just a cloud of fog. So brain fog, and then relating it to chemotherapy, there isn't solid evidence, but we know it's a definite thing. The latest Macmillan survey said that 78% of people that are on treatment or newly diagnosed have some sort of brain fog or some sort of cognitive slowness in their function. We think that it's probably dose dependent, so the more chemotherapy you have, the more likely you might be to have brain fog. We think it might be age related. Again, as we get older, we definitely become less sharp, but does chemotherapy rush that along a little bit? And we also know that sort of this chemotherapy related brain fog isn't only related to chemotherapy, it can be disease related. You know, is that related to stress? Is it related to mood, depression? I wrote manic there, but I meant really for manic to be sort of tied with the steroids, where you're all on for 1 minute and then you're off the next minute. But it's really, really difficult to give sort of precise answers because there isn't solid evidence, and that's because all these symptoms are so subjective. So it's really difficult to gather the evidence in. So what you do really is you fall back on the things that you can measure. So I tried to have a good look around at all the sort of research that was available. I could see that they were definitely looking into studying brain fog, seeing what chemo drugs might be more related, looking to see whether there are drugs that might protect the brain, but there aren't any actual studies open in the UK at the moment. I picked this study just to share with you because it was only published a couple of weeks ago, and this is the sort of the typical type of evidence that we get. So we're using measures that we can use, so quality of life and sort of role functioning measures. And this study actually that was published only a few weeks ago said that 1 in 3 people with non-Hodgkin's lymphoma still report persistent symptoms of fatigue and role functioning impairment, and that's 10 years after diagnosis. So they wanted to talk about chemo brain, if you read the article, but the way they sort of had to interpret it was within these sort of measurable objective measures. So just not to get people depressed, because I mentioned that it can go on for 10 years. This again is off the Lymphoma Action website. So chemo brain was short term for me, but I felt angry and frustrated when I couldn't remember words or their associations. So really, again, showing just how chemo brain is different for different people. So looking at things more positively, really, what can we do about it? So I think a lot of it really is you have to be very active. So you have to be positive in what you're doing. The first thing is really understanding it, knowing that, you know, if you are being given poisons or if your body's coping with a lot of disease, you know, your brain isn't going to be functioning at, you know, 120%. And part of that is you have to sort of learn to accept that bit and sort of, you know, really arrange your day around it, when do the things that you need to be most alert for when you are most alert. And then address the issues that you do have control over. So diet, definitely eating a good diet helps. If you're eating takeaways, fatty foods, you know, that is going to slow down your cognitive thinking. And also get support for your emotional well-being, because stress can definitely, you know, stop you functioning cognitively. I'm a big fan of physical activity, so being active really has a positive effect on thinking, memory, attention, and speech. It can lift your mood as well, which in turn can help your thinking processes. So really, it's sort of picking out for you what you can do in your life to sort of make positive changes. Again, I would direct you to the Lymphoma Action website, because there's a wealth of sort of hints and tips of what you can do, and a lot of them really are things related to fatigue management. So, write down things, focus on tasks, get help when you need to get help. Do a diary to see if you can see a pattern of when your concentration levels are higher or lower. But there are lots of really helpful tips to have a look at. So going a step further, you can also get more specialist help from trained professionals, and really there are psychology support. So our psychologists will do things like cognitive behavioural therapy or memory and attention adaptation training, which really gets your brain to focus on different ways of doing things. When you think, oh, I can't handle this at all, you can be taught some techniques to think, right, let's just go step by step, we can do this. And I would say, as brilliant as psychologists are, sometimes they are difficult to get hold of or to access, but on your own, you can be really active yourself and do some brain training games and puzzles, because if you don't use it, you lose it. So I always say this to patients when I see them after chemotherapy. Really, it's not only physical rehabilitation, you need some mental rehabilitation. You need to keep your brain cells active or get them used to being more active again. So that was a bit of a whistle-stop tour. I did have a few questions that were sent in, which I think I've covered most of them, but there were a couple of extra ones. So what causes chemo brain? I think I mentioned a few of them, but can rituximab cause it? So rituximab is an antibody treatment, and I would say anything can cause chemo brain. Rituximab makes your immune system respond to disease, and if your body is responding, it means that it's active. So you can definitely have some sort of slowness in your cognitive thinking for many treatments, including rituximab. But I would say that's probably not evidence-based, but again, from experience. And the same, another question was, can radiotherapy cause it? So radiotherapy definitely causes a lot of fatigue, and fatigue will definitely cause some cognitive slowness. So again, although telling you the evidence is very difficult to say there's a definite link, but I would say from experience there is. When will it get better? So it's very much an individual thing. Some people will get their cognitive function back quicker than others. Some people work really hard at it, and others can't so much. But I'd say everybody is very different. Some people tolerate sort of the really heavy chemotherapy really easily, and some people struggle with easier chemotherapy. So, it's all very, very subjective. Can it be permanent? I would say yes, probably. I think chemotherapy does change a person altogether. It gives you a different perspective on life. You go through a lot of stress, and I think you do come out the other side a different person. So if you relate that to chemo brain, I would say, some of that sort of sharpness that you might have had when you were younger or before chemotherapy can definitely be lost. Again, whether you can blame the chemotherapy or aging, it's very difficult to say. Can it get worse? Again, there's no evidence to say, can it get worse or can it get better? But I would probably say, if you work at it, it shouldn't you shouldn't suddenly deteriorate a few years after chemotherapy. You know, it won't be related to the chemotherapy if you're having cognitive problems suddenly. But I would say everybody is different, and I would, you know, ask advice from your healthcare professionals if you're worried about anything. And I think that's about all the questions I had. I don't know if Anne's got any more for me.
Hello, Charlotte. Thank you ever so much for that. And thank you for sharing your wealth of experience on this topic and explaining the challenges of brain fog. We also had a question that said, should people be prepared for symptoms and side effects at the start of their lymphoma journey? And would this help them cope and manage with them? What are your thoughts on that, Charlotte?
So, I mean, I would hope that everybody is given a lot of information about the possible symptoms and side effects. You know, it's a bit like if you're taking paracetamol and you open up the list and there's thousands of side effects, but whether it happens to you or not is a different thing. So I think it's important to give everybody information. How that's taken in is really difficult. And I think it's very much, I think once you've tried it, the understanding comes, and that's when people sort of link things back to each other. So I feel it's really hard to tell people what to expect when everybody has different experience.
Thank you. I don't know whether we can bring everyone back on the screen as we wind up this webinar. Maybe we can't find Nikki, but I wanted to say a big thank you, Dan, to you, to Nikki and to Charlotte for 3 absolutely fascinating presentations. I'd also like to thank our audience for listening in today. So once again, thank you to all of you for such a fascinating afternoon. And with that, I'm going to close the meeting. So farewell to everyone.